seen that the amazing British weather is playing Russian roulette. It's turning warm, but then you never just when you think it's summertime, you've got these wonderful clouds making you remember, don't take us for granted. It's going to turn cool any moment, and that might be the end of the weather you see. But then, for the health services, nothing has changed. It's been relentless. Good evening, colleagues. I'm Dr. Mohit Venkatram. I'm the Deputy Chief Exec of Northeast London Foundation Trust, and this is the Future of Primary Care webinars. Many of you who have been with me on this journey for a couple of years now would be aware that this is a space we created to have some thinking time to ourselves, to learn together and grow together as a community who wants to make a difference to the outcomes our local residents receive. 9th of May, very recently, marked the first anniversary of the plan for access for primary care. But for those of us who have been working in primary care for years, many of these things have already been implemented. We've been grappling with this for some time to deliver the safest, most effective care for our residents. There are some fundamental changes, though. The implementation of the widening for primary care and community pharmacy services is such a welcome addition to the pathway to deliver more integrated, more access to the health services than we have had previously. As a large foundation trust, we have always recognized the strong roles our amazing primary care colleagues play in delivering safe services. A resilient and strong primary care for us is the only way we can support what our communities need: earlier, quicker, safer, better, effective care that is close to them. As a large corporate organization, Northeast London Foundation Trust and our sister colleague, Foundation Trust, East London Foundation Trust, recognizes that we have a crucial role to play in providing that resilience to primary care services by sharing the large corporate resources we have, because our GP colleagues, our primary care nurses, work really hard and deliver fabulous, effective clinical services. But if we could share those corporate resources that we had with them together as a system, we could deliver absolute magic in healthcare for our communities. This space, the learning space, is one such effort put in by organizations like us, committing us to supporting our colleagues who work in primary care. So, despite the hard work they put in, last month, many of you would have read that the reports indicated the attendance to A&E was the highest ever recorded post-pandemic. While there was so much of focus on that A&E attendance, no one recognized that almost 30 million appointments were delivered in the month of March alone in primary care. 65% of these appointments were delivered face-to-face. Now, the statistic that really stood out to me was that 45% of these appointments were same-day appointments, which means in a country with a population of 58 million people, 13.5 million people accessed care on the same day in primary care. So when we talk about the fabulous delivery in A&E and the high demand for A&E, think of the proportion receiving the same care within primary care. Without a murmur, these amazing colleagues working in primary care continue to work as strong pillars of the foundations of which the NHS was established. Against this background, it raises the question, and the fundamental question it raises is, if the A&E is still having these challenges and primary care is doing so hard, working so hard, working so well, what could we do fundamentally rather than working as a primary care, secondary care system? Could we integrate the system and deliver more effective care? There are very few models of vertical integration that exist across primary and acute care services. One such place, which has been the forerunner for the whole country, was Dudley. And I'm so incredibly pleased that today, among us, our guest for today's webinar is the fabulous Dr. Lucy Martin, who provided all the medical leadership in Dudley for the delivery of the first ever integrated vertical model in this country. Dr. Lucy Martin is probably one of those really broad-shouldered, broad-experienced, amazing clinicians in primary care who has a wealth of experience all the way from palliative care, cancer care, working as a Macmillan's facilitator, all the way to becoming the medical director of Dudley Integrated Care System. I recall in 2016, when Dudley was first being touted as the integrated care model in the country to look up to, I was in the US. And that was when Dr. Lucy Martin burst on the national screen. And since then, Lucy has continued to make waves in so many ways and inspire so many of us for what's been happening. It's my incredible privilege today to welcome Lucy. But just before I hand over to Dr. Martin, I just want to remind colleagues, many of you know, we have been live broadcasting our webinars for the last few months. Today's webinar is no different. We are live across many platforms. Almost 300 of you have registered on these platforms for us today. Some of you have already posted your questions to me, so I will be using them as a starting point to have the conversation with Dr. Martin. But for those of you who are on the Zoom platform, please use the Q&A button to post your question, and I will then pull out the themes when we start talking. But before I do, I have the privilege of handing it over to Dr. Lucy Martin. Lucy, welcome, and thank you so much for joining us today.
Thank you so much for having me. It's a great introduction. I don't quite recognise myself there, but thank you all the same. I think that's one of the common themes, isn't it, about general practitioners that are doing leadership roles, that we just see ourselves as ordinary folk getting on with the job. Anyway, so thank you for having me. I'm going to tell you a bit of a story about Dudley, which does begin around about 10 years ago, where a group of GPs working in Dudley CCG, which is around about 320,000 people in our town, they had a vision of how they thought community care needed to be. And I think a lot of GPs and other clinicians recognise that the reasons for this are happening around us. There's lots of changes in the UK population. We know the needs that people have as they get older. We see in our day-to-day life, don't we, the problems that many of our patients have with navigating the very complex care systems that they have to deal with when they've got multiple comorbidities. And as you've described very well in your opening statement with the stats that care is very much reactive rather than proactive. One of the things, particularly where I work and I see around me every day, is that health inequity, and you see it every day in your consulting room, and so you're working with people all the time that will experience this health inequity every day. So that they took this kind of framing and designed and bid for some innovation funding for a new model of care, and the idea is to attempt to address some of these issues. And as a result, successfully formed a new NHS body, which is Dudley Integrated Health and Care, to deliver the integrated care. So we fast forward from 10 years ago to 2024, and this NHS body is now being dissolved in about 6.5 weeks' time. But of course, the problems that I described before still exist, and I think in many respects have worsened further than they were 10 years ago. So yeah, as Mohit said, I'm a GP partner. I work in central Dudley. I'm from Dudley. I was born here. I was raised here. I'm sitting in my front room in a house in Dudley as well. I'm what we describe as a portfolio GP. So I work half the week, 5 sessions in my partnership, and then I work for the rest of the 5 sessions as a medical director for the IHC. So yes, as I say, it will be disbanded very soon. So Mohit's asked me to share some of the things that I've learned as a GP working in Dudley. So I'm going to cover a little bit about the original vision and how that panned out, and then a bit about the journey to get where we are today, and then what we are experiencing today, and then what we think will come next for people in Dudley. It feels a little bit like I just need to make sure that you know that these are my learnings, I suppose, rather than necessarily assuming that all of the people that I work with would agree. And I think, as Mahid said, as in many of the presentations before on this channel, that just because something may or may not work in Dudley, it doesn't mean that it's applicable around the country in the same way. But hopefully you can get some nuggets of at least interest for your own areas. I think it seems to me that lots of people are having similar ideas at the moment around what might be the next thing for how to successfully deliver primary care. I really want to resist calling it out of hospital care, because I feel like it's just defaulting that hospital is the default, and just simply referring to primary care and community care as out of hospital sort of just adds weight to that hospital being the default model. So I'm going to stick with primary and community care. So yeah, I think just while Dudley hasn't necessarily succeeded in its original plan, it doesn't mean that the issues have gone away. It certainly doesn't mean the vision has gone away. And hopefully the will to do things differently still hasn't gone away with me and my colleagues as well. So just the first slide is, none of these slides are very interesting, so it's just so you don't have to look at my face for so long. The 5-year forward view, I mean, many of you will remember this, came out in 2014, so 10 years ago. And some of you perhaps will not. There's been so many documents, haven't there, over the years that they all sort of blend into one. But this was developed by partner organisations that deliver and oversee health and care services. So the CQC, Public Health England, NHS England and Improvement. And they took advice from patient groups, clinicians, independent people to describe how the health service needs to change if it was to close some of those widening gaps in the health of the population, the differences in quality of care and funding of services. They wanted to, specifically, these are quotes from the plan, that a radical upgrade of prevention and in public health, patients gaining control of their own care, and that this was the launch of personal health budgets, breaking down barriers in how care is provided, and developing new care models, of which the MCP, or the multi-specialty community provider, was one. This was about groups of GPs really combining forces with other community health services and consultants, particularly delivering care together. There was also an intent that this would include probably mental health care and social care as well in time. The bit I liked in the 5-year forward view was the quote about having a new deal for GPs, stabilising core funding, investment in primary care, more control by CCGs over the commissioning budget. So I don't know, we all know how that went. Anyway, so back in 2014, we were granted funding from this five-year forward view approach, and we were termed at the time as one of the new care model vanguards. And we chose the MCP approach as our vanguard model, where the intent was to move specialist care out of hospital into the community. So to be close to the patient, and really basing that around the general practice as being the hub, the registered list, and the way we would wrap care around the patient as they were registered with their practices. So the CCG, we were, I think, a very forward-thinking CCG, which was very GP focused. We had a lot of GP leadership on the board and in the executive. We worked then as the commissioner to procure a new type of contract. So the idea was that this contract would be a much longer one than normal. So a 15-year contract, with the idea to be able to use that time period to deliver a shared approach to patient outcomes across the health economy. So it's very difficult to achieve longer term preventative type outcomes in a 12-month contract. So the idea was always to have a long contract to make sure that we would have time to be able to deliver the outcomes that we wanted to. And those outcomes were really aimed around the wider determinants of health. And so they would make that the outcome measures were hard, stretch targets, I guess, hard to achieve. So things such as school readiness or employment rates, and taking a much more kind of proactive and preventative approach to health. So as I say, the bid was awarded, and we then joined together with some of our local provider partners to achieve this joint model. The idea, as I say, we're all working towards the same targets over time, and we started a procurement process for this contract, which is called the Integrated Care Provider Contract, the ICP contract. It has become quite confusing talking about ICP. Now we have ICB. So yes, NHS acronyms are always here to stay, aren't they? So we agreed that to deliver this MCP approach with this contract, we would need a new type of NHS organisation to do this. And then the idea was that the partners that we agreed with at the time would each transfer the community services that they held into the new organisation. So it would quite quickly achieve a large scale approach, and then be able to deliver this multi-million-pound contract over the 15 years. Figures that were bandied around at the time were £250 million pound contract. That's purely just the value of the contract times by 15 years. But it's obviously it's a lot of money, and it's a lot of public money. So there was a lot of a scrutiny, I suppose, on us and how it would work and whether it would be successful. So instead of being able to starting an NHS organisation from scratch, which would have been very long-winded and difficult, we were fortunate, I suppose, in a way that one of the local mental health trusts merged with another trust and left an empty NHS trust shell, which we were able to just take over and inhabit quite quickly. And that happened right at the beginning of the pandemic. So it enabled us to set up a board and an executive quite quickly. The idea was always that this would be different to your traditional NHS trust. It was intended to have the sort of agility and forward-thinking responsiveness, I suppose, of how we work as GPs. You know what it's like. We see a problem in the practice, we sort it out, the process has changed, and we fixed it by the next day. So it was supposed to take those kind of agile mindsets and put that into a new type of NHS trust. But also then to have the security and governance and I suppose the heft of an NHS trust behind it, with that ability to work at scale, and then the safety aspects of proper governance structures. I think, again, one of the criticisms that people often have of general practice is that the governance is a bit opaque perhaps, and it's not easy for other people to understand. So we formed literally right at the beginning of the pandemic, and the trust started on the 1st of April 2020. So I think one of the interesting things that people know about us is that in Dudley we had around 46 practices, I think, at the time. It's now down to 43. And at that point, most of the 40-something practices became partially integrated with the trust. So it wasn't the traditional, if you can call it traditional, the vertical integrated model that you get with other organisations where the trust took over the running of the practices. There was one practice that we took on as a fully integrated practice where the trust runs it. Another one came aboard later, and I'll tell you about that in a bit. But the remaining practices, apart from two who decided not to get involved, one became partially integrated with the trust. So they were still run on their own GMS contracts. They still delivered general practice in the way you would understand. But it meant that each practice signed up to a specific integration agreement, which was in cooperation with both them as their practice, the commissioner, and then the provider trust as well. And the principles around the integration agreement are things that I think a lot of people are quite interested in, because it's very difficult to get many practices to work together in such a way. And I think one of the learnings that we've had is how we have managed to successfully do that. So I'll just describe a little bit about the integration agreement and the kind of contents of that, and see if there are things that you kind of recognise that you might be able to forge forward in your own areas. So they were really a series of commitments, I suppose, a set of principles around the purpose of the integration. Was really that one of them was to develop and implement a primary care strategy. Sorry, I should have said next slide, please, shouldn't I? One of them was to integrate the primary with the community services, public health, social care, and the voluntary sector. Working together to achieve a set of, I don't know, integration activities, I suppose, that define a shared vision for developing that sustainable model of primary care. At the same time, trying to support and reduce the demand in unplanned care. So we developed this idea of integrated care teams, which is a sort of super MDT, I guess, for want of a better explanation. We'll come back to that. We wanted to develop very much a focus on population health management. So clinical services operate into these specific outcomes, focusing on prevention, so being more proactive rather than reactive. So that's the sort of purpose statements. Then we would agree to a clinical model that we would all work together. We all went into the same primary care computer system, so we all moved to EMIS. Some of us were already on EMIS and some weren't, and so some people moved to EMIS specifically so we could have an integrated approach to data sharing. The idea was that the community services within the trust would have a triumvirate management structure, so similar to the triumvirates you get in many trusts in their divisions, where you had a GP, a lead nurse, and a lead manager operating community services. That was always the intention. We developed the model in mind with that intention of providing as many services as we could at that ICT, so the PCN level, making sure that at the heart of it all was improved quality of care. So we had a practice-based approach where we developed our own quality and outcomes framework, which is known as the DQOF. So it has many aspects similar to National QOF, but also has some very specific areas of focus for our population, and many of the payment is very much stacked into the preventative aspect. So looking at care planning, a holistic long-term condition reviews, that type of thing. So effectively, the idea was that the clinical model was for the whole place. So there would be the practice level through the DQOF. There would be PCN level through these ICTs, these super MDTs, and then across the borough through the design of the clinical hub, which I think, again, many of you are familiar with the approach. In the integration agreement, another key aspect was about the relationships with the PCNs, because, of course, PCNs had sprung up while we were going through this process. And one of the key elements, again, for this trust provider was that the trust could provide and subcontract PCN DES services. So we were to be the employer of all the ARS funded staff and services, and then also to be a provider for the practices and PCN's enhanced access. But then all of the PCN CDs would be involved and have a central role in the governance of all of this stuff. So we formed a committee where the CDs sit, and so they have a direction and influence on the direction of travel of the trust. So that was how it worked with PCNs. And then the CCG also then delegated their primary care development function too. They had We wanted to look at things like joint workforce planning. We wanted to look at joint education. We wanted to do things around supporting practices with all the different things that they might need help with. So from things like CQC compliance, remedying problems after CQC inspections, GMS performance issues, but also things like HR support, finance support, buddying with colleagues, training, mentorship, all sorts of stuff. Effectively having access to a kind of a quality team to be able to support remedial action and also supportive action planning for practices. And then also having a communications team, so they were able to support practices and PCNs with a lot of their patient engagement and public engagement work that is challenging for practices to meet. So yes, once we'd kind of got that practice agreement in place and everybody signed up to that, the next step for the trust was to receive some services. So in around the October of that first year, we received some over those next few months. So we got the delegated commissioning staff from the CCG, including some of the corporate support functions to support the just running a trust. We got continuing healthcare and intermediate care teams. We got a significant amount of clinical leadership, which we're still on the old slides still. It's pointless, really, the slides. The clinical leadership, so we had a lot of GPs who were doing 1-2 sessions working in specific clinical areas. And then we had one GP practice that came in as well at that time. They were an APMS contract, about 4,000 patients in one of the really most deprived parts of the borough. We also took our quite large team of practice-based pharmacists. So these were around about 55-ish individuals that was commissioned jointly between public health and PCNs. So they were there to work together as providing that wider team pharmacy support to practice, but also with that kind of preventative agenda in mind. We took on primary care mental health services and IAPT, those kinds of things. And then we took on the funding to be able to employ ARS. So not so many ARS to begin with, but as time went by, employing pretty much to full capacity funding in all of our 6 PCNs. And then later we received the school nursing service, which had been, although the nurses were based in schools around Dudley, they were provided by Shropcom, which is a different neighbouring county provider that looked after them. So we took them in, and then we took another practice that had problems with CQC. They had a retiring partner that needed to be able to hand on their contract. Again, what was interesting, we were able to take a GMS contract as a trust, and we did this with a workaround using the GPs within who are employed by the service. So effectively not me, although I am the GMS holder now for this practice. One of my colleagues who was working with me as medical director, we did a job share. He took the GMS contract and went into partnership with the retiring partner. And then the retiring partner left. We put another staff member, another board member on the contract as well. So we were able to hold a GMS contract, which is fairly unusual for an organisation. APMS can be given directly to an organisation, but GMS has to still be held by a GP. And then we started some things around that. So the GP education that had been paused during COVID, we reinstated that. And one of the more interesting things that I've been involved with, I think, is to develop from zero and no provision whatsoever to develop a fairly thriving primary care research hub within the trust, where we're operating NIHR and commercial studies as well. We do your traditional GP type EMIS based search and offer a research project to our patients, but we also do our own research. So we've got a really interesting trial at the moment called the Harmony trial, which is looking at vaccination of babies under 1 with a monoclonal antibody against RSV. So there's been lots of interesting stuff happening around primary care research. Which I feel particularly passionate about, because our 2 surgeries are very, again, in very deprived populations, of which the demographics don't tend to get access to research in the traditional sense. So to be able to offer primary care research to those patients is something quite new and exciting to be able to do. So we're up to around about 2021-ish now, and then a hiatus happened. Services that were due to be transferred were paused. Providers that were due to transfer their services to us became concerned and started to challenge the process of transfer. It's cutting this quite long and painful period into a very short couple of statements, really, that as a result of this, and a lot of toing and froing between regional, national, NHS England and others, the ICB then started a review of the future of DIHC in 2022. And I think this came along because of the landscape, I suppose, of healthcare in the UK post-pandemic. There was we all know about funding pressures and the huge deficits, and I think at the time Black Country ICB, where we work, was the first or second worst, most in deficit. So we had a lot of money to find, and having an independently run primary care organisation that didn't actually have that many services in it seemed probably a little bit wasteful. And because the organisation never really managed to achieve the scale it was supposed to have had, because the large number of services that were going to transfer never did, it was then at that time it still is the smallest trust in England. So we were running a full board, corporate services, and all of the things that a trust has to have. But it was becoming harder and harder to justify the existence of that with that backdrop of austerity and needing to make significant budget cuts to try and make up the deficit. It's always a hard one to argue that for GPs, I think, because GPs run their businesses as efficiently as they can, don't they? And practices will always say, well, I'm not in deficit. Why am I having to support a system deficit that's not of my making? And that's a really challenging one to have a conversation with GPs about. And I still don't think we did that very well. I don't think GPs really get that. And I don't think it's easy to understand that the system deficit is everybody's deficit. It's a political one, and it's difficult to justify that one. So, as you're probably aware, at the same time as this was happening, many of the bigger organisations were also joining at the same time. So you're getting trusts moving together, starting to share boards, forming these lead providers, forming acute and provider collaboratives. So the direction of travel for us as a very small trust was very, very much swimming against the tide. So as a result, in November 22, the system then agreed that the existing services should transfer to other providers and that the trust should be dissolved. So it's logical, isn't it, when you think about it? But obviously it's very disappointing, and it's been very hard, I think, for a lot of the colleagues that have worked so hard on this for 10 years to accept that it feels a bit like the dream is over. I don't think it is, but as you can imagine, I'm sure it's hard for GPs to come to terms with that. It feels like a bereavement. It feels like grief. So now I am on this slide now that you've moved to, which is just to remind me about where we are now, I guess. So that's kind of the journey to today in 2024. Where we are now is that we have a dissolution timetable. We're going through a process of transition, as it's called. We've had to go through a significant process of due diligence and then quality impact assessments. And in fact, we are actually transferring our services now out to 9 different providers, which includes the acute trust, a community trust, a mental health trust, back to the ICB, some of the different PCNs. There is an NHS framework to support dissolution of trusts and merging, but it's actually doesn't normally include the number of organisations that we're dealing with. Maybe you might have 1 or 2 transfers, but not 9. So that's been a huge amount of work, as you can imagine, just to get through the processes that need to be done to get this right and get this delivered on time. One of the things that the GPs and we acknowledge for patients as well, that this has taken so long, and people just want to get on with the job now. It's kind of the king is dead, long live the king. We know the trust is gone and it's finished, so we want to get on with the next phase now. But it's very difficult to get that moving because we've got such a lot of work to try and achieve that. And also, we're a sovereign organisation. We have our board. Our board wants us to, they want to be assured that the reason they set this trust up is not going to be lost. So they want to see that at least there will be, we've got this principle called the equal or better principle. So They want to see that when we're transferring our services out to these other providers, that the services will at least be equal to where they are now, and then hopefully better. We will not accept that if a service transfers, it will become worse for patients. So it's been a long process to, again, try and convince the board. It's like turkeys preparing themselves for Christmas, I think you might say. We've had a lot of work to do to try and convince the board that we can safely transfer services out of our trust into new ones. However, we are on track for the 1st of July. So yes. In the again, alongside this, we've got the Black Country ICB operating model. So they've designed a new operating model that they want to work to. And we have 4 places in the Black Country: Dudley, Sandwell, Wolverhampton, Walsall. And part of their operating model includes that we have to have 4 place-based partnerships. We have to have 4 place-based primary care collaboratives. So they've all been set up and have been working for around about 18 months now. We have a wider Black Country primary care collaborative where all the 4 place-based primary care collaboratives feed into. Of course, we've got a Black Country provider collaborative, so that's where all of our acutes will sit together. And then there's a lead provider for mental health, learning disability, and autism. So this is the model where the ICB over time will ideally be able to devolve more resource and decision making out to these organisations. And then alongside all of this, we've formed this Dudley place-based partnership, which again, many people are doing a very similar thing around the country. It's made up of our partner organisations. So it's made up of Dudley Primary Care Collaborative. At the moment, it's got Shropshire Community Health in it because the school nurses have now transferred back to them. We've got Black Country Healthcare, our mental health trust. We've got Dudley Group of Hospitals, who is our acute trust. We've got the voluntary sector from Dudley, Health Watch, Dudley Council, and also DIHC as a trust. So that's how it's working at the moment. It's in its forming stage. There are some pieces of work that are being done, but it's we can go on to the next slide. We've got a logo. It was formed originally in 2022. So all of these things have sprung up around each other at the same sort of time. So hopefully that's not too baffling, because I mean, it's been hard really to clearly articulate, I suppose, what's happening here.
Yeah, come in for a minute. So
yeah, do.
I know it must feel hard and it must be difficult to go through, but I did want to share something with you, which a colleague of mine has just posted. While you're talking about the mechanics of the organization and the changes you're going through, actually, a colleague of mine has just said she has a friend who has now passed away, who was in Dudley.
Mm.
And she said her end-of-life care in Dudley was the best she could have ever received.
Well,
and my friends just said,
that's an important review.
Should we not have, wouldn't be wonderful if we could learn from that model? So I think I see success in that, because irrespective of the organizational model, the ability to improve care for the service user and the resident is what we actually came for. The whole concept of Dudley Integrated Care is not the organization, isn't it? It is to provide something that would be easy for people to access, really care for them, wrap around them. So I think you should be immensely proud of that as the outcome, because what's been achieved is phenomenal. And there are people posting questions about stuff, and they've emailed me on questions, and it'd be brilliant. I mean, let's wrap up what you want to say quickly so that we can ask the questions. Absolutely phenomenal what you've achieved.
I realise now I've rambled on for quite some time, so I'm sorry for that. I guess it's hard to explain 10 years worth of work in a short period, isn't it? I think there are some helpful benefits, and I'd just like to very quickly run through them, just headlines, the things that have worked well as a result of us doing this work. So the first thing I think to say is the unification of practices. That is really hard to herd 46 cats in any direction, and we have managed to do that. And so I think that relationship will remain. We can build on that. I don't see why there's any reason we can't build on that, and people can continue to build work around in Dudley Place around that idea. What's been really helpful, I think, again, is employment for ARS staff. We've got NHS terms and conditions. We haven't got any competition with each other. It's a single employer, so we retain and recruit very well. That's been really helpful. The DQuaff has been a really good model of developing your own bespoke quality and outcomes framework. And again, weighting it towards prevention has been a challenge for us, but it's been deliverable. The way the MDTs work, this what we did call the ICT, but now it's called the CPT, because there's nothing like an acronym apart from changing it to something else. CPT stands for Community Partnership Team. So this is an enhanced team that works in that wraparound way around the patient. We're doing some specialist work with diabetes, mental illness, respiratory, where consultants are coming in and joining those MDTs, and we're making some good progress there. I think there's a lot more to be done with that. We've got plenty of BI that we can obtain from EMIS and primary care systems around, I don't know, frequent service users or more complex patients. So we've got a lot of work we can do there. The primary care research is brilliant. I really wouldn't underestimate how hard it is to get from 0 to 100 miles an hour in a few months, with particularly getting commercial research. It generates income, so that's really important. Something about VI. We have 2 practices at the moment. VI isn't that successful in terms of improving practices. It delivers a little bit of reduction in activity around A&E and stuff, but those aren't sustainable. They don't last for a while. There's a report on VI, the Brace 6 report, the Brace VI report. There's no improvements in QoF with VI practices, but we've managed to deliver 20% improvement in QoF in one of our practices and about 9%, I think, in the other one. So we have made some real difference to quality of care there. It's good to have a primary care strategy. I think I'd say the ICB want to take lots of elements of the strategy that we've designed and use it for the whole ICB. And then I think we've got this sort of germs of an alternative GP provider. One of the things that we've all noticed, I'm sure, is how the partnership model does work in a lot of scenarios, doesn't it? It's far from dead. It's far from dead, but there are still lots of practices that are struggling. There's a lot of young GPs who don't want a partnership risk, but they might still want responsibility and they want to get involved with quality improvement and service development. But with such a flat sort of career structure, it's difficult to offer people that type of work without a partnership. So I think we have that within the trust, and an ability to perhaps do that with some of our younger GPs to develop them in a different career. So I think there's a lot of opportunity there. And then, Claire Fuller thinks that this is one of the ways forward in the future of primary care. So I think there's lots to be done that we could do at scale. I think about maybe taking the boring stuff that we all find challenging in our practices, perhaps about ordering consumables, industrialization of some of the difficult to fill stuff like coding and summarizing of records, or docman record reading, records management, HR, payroll. There's lots of things that a place-based partnership could take over for practices. So perhaps to free them up to do the stuff that they do well, free them up with their clinical work and their innovation and the things that GPs always have done well. I think there's a lot to come. Working with some of the virtual wards, I think, is really interesting. I think, and then ultimately hopefully taking the community services in due course in our new trust, which will be the acute trust.
I have to say, it is incredible what you've achieved over the last 10 years. It is absolutely incredible. And if you're okay, let's put the slide down, because there are a couple of
really I'm done really with my rambling.
And then it was amazing what you've said. It was a minefield of absolute gold nuggets that one got to hear. And it's incredible success, because what you have proved today was the value set with which one goes in is more important than the organizational structure that lasts. Because what you've created now in Dudley is that ethos of joint working, which has outlived the organization. Many of us working in large trusts have aspired to do and not been able to achieve what you have achieved and spoken of today. And I actually see success there, which very few have managed to achieve. And it's fabulous to see the ability to attract workforce, because I've now been a doctor for 33 years of my life. And I can say fundamentally, loads of things have changed, but 2 things have never changed. One is the need to continuously focus on the need of what the clients are. What does the residents want? What do the patients want? And how do we make sure that they get the best care?
Mm.
And the second, to get the first right, is to attract the right group of people.
Mm.
And in Dudley, you seem to have done cracked both those things in a way that very few people have. So it's absolutely phenomenal. And I think the question I would like to put to you, Lucy, in the Dudley context is, how did you get people? And I know you use the term, it's like herding sheep together to get 46 practices to work together. But actually, we are talking about some very, very experienced, hardworking clinicians with considerable experience. These aren't people who just sign on a whim to say, okay, I will listen to you. These are people who are guided by a moral compass. That's why we became doctors and nurses and physiotherapists and the likes. That's why we became clinicians. I mean, in all honesty, it wasn't the money that attracted us because we could have made more money elsewhere.
Mm.
There was a value set, a compass. How did you get that work done to achieve what was achieved in Dudley this quickly?
It took longer than perhaps I give credit for here. There was a lot of engagement work, a lot of going out, knocking on doors, speaking to people, reassuring them. So this was pre PCNs, so key GPs really who took on the role, I suppose, of a similar role to a CD. Now they were well-respected GPs in their area, taking up the mantle of this story and going out and explaining the vision. We were expecting GPs to give up some of their autonomy, that we were to in exchange for what they saw as the ultimate goal, which was to gain control of community services, to be able to deliver them in a way that we felt was the best way for our patients. And I think that that's exactly it. It was a hearts and minds, it was a hearts and minds experience trying to get people to buy into that. And it did work, and I think that is, as I say, I think that is one of the legacies that we still have that to a large degree, even though there's been a bit of fragmentation in terms of the services at the moment. That
think
will is still there.
I personally, Lucy, don't see the fragmentation. I'll be honest. I see the contractual fragmentation,
Mm.
but I don't see the service fragmentation because actually that bonding that's been formed in Dudley will never go away. People who work in Dudley, I mean, today what I've heard from you is all about the hearts and minds of being part of a community. But I'm going to flip this around to ask another question now. And it's not a question that people have posted, but there's a theme that's come out to me. The why
Mm.
of the Dudley formation. How were the residents, the people who lived there, how were they part of this development of the architecture and the value and the vision set?
It was very much part of the process, and to even take the bid into the vanguard stage, you had to have an extensive amount of patient engagement and patient involvement. So there was a lot of going out and pounding the streets, interviewing people, focus groups, that type of stuff. And patients were very very enthused about this idea because again, we all know, service is so complex and difficult to navigate that they saw any way of bringing them together in a way they didn't have to repeat their story multiple times, in a way that there was maybe going to be a shared record approach with everybody working for them rather than them having to work around us. So that it was a no-brainer really with patients. They love the idea, and it's quite difficult and challenging to try and go to them and say things haven't moved in the way we wanted it to. But as I say, patients won't notice any change of service as we change from one provider to another. We still have that vision in place now, and we can still do the work that we need to, I think, for our patients.
And I think it's brilliant, isn't it? I mean, it's really interesting how we all call ourselves different trusts. I mean, you spoke about at least 3 different trusts when you're unwinding your contracts. And many of us recognize trust only because we work in this sector. But the reality of it is, if I was just an ordinary resident on the ground working in a shop, would I recognize a GP is different from a trust? I see them all as one NHS. So it's meaningless to me whether the district nurse comes from this organization and the health visitor comes from another, as long as when my family needs the care, I know where I can go and I can. So I think simplifying the system by forming bonds and involving people earlier so that they had a say in what the pathway should look like is such a nice way of trying to set the why And it gives me a understanding of why Dudley was successful. And I'm not going to get caught in the conversation about, oh, but it's being unwound. The unwinding is contractual, it's meaningless,
Yeah.
it's organizational. The hearts and minds and the why will always outlive that unwinding. It's no one can unwind that part of the process. And I think that's a crucial success. But Lizzie, I mean, there are many callers here today who would want to understand the one question. Many people are talking about vertical integration, and it's being touted as the answer to the world. And are one of the few people in the country who can talk from it, not from an experiential ground alone, but also from the heart of what it means to you as both a clinician, as a leader, as a community person. Because one of the advantages of being in the shires and in being outside large cities is you are part of the same community you're serving. And so it means a lot to you.
Mm.
If I had to ask you today, with all the experience you have, what's the one thing you would not do now from the experience and the learning you've had? What would be your one thing for others to take back and say, that's the thing we need to be careful of and not do?
I think it's probably around getting bogged down with contractual stuff. The contract, although it was seen to be the herald of kind of the future, it actually was the thing that sunk us in the end. We were very much concerned with form before function, whereas I think it's the other way around, and probably that is the lesson, that you think about function before you think about form. What is it that we need to do? How do we need to do that together? Let's write it down afterwards.
Phenomenal. I'm so glad you said that, because actually all these years, having worked in so many organizations and so many guises, I think I have worked in primary care trusts and CCGs, and I've worked even in social care, and I worked in acute trusts, and I worked in GP practices. The one thing that should never change, and that's the thing we all need to be guided by in the NHS, is what we are here for fundamentally is to improve the outcomes for the residents. And that's what we need to stay focused on. It's really interesting the amount of distraction that comes from every part of the system. And I mean, I know there's some fundamental questions here that say, well, if didn't have enough money to do, now the acute trusts are in deficit. So are we going to unwind those, or is that the way to go? But actually, it's not an acute trust deficit. My personal view is it's the common man who's losing out, the person on the street. It's their money we've been entrusted with to take care of and do the best we possibly can. So the answers should also come from asking the common man, what's the waste? What do you think we are doing which is completely useless, not adding value? Let's just stop doing that so that they get the right outcome. So it was a fabulous answer to hear that from you, to say, don't get bogged down by form, focus on the function, stay true to the value set that you came in. On the flip side of this, how do the staff feel about the opportunities that came from this big development? What did you attract? Did you manage to attract more people from outside who made Dudley their home?
Yeah, there was a real strong culture piece around this, that people came to DIHC because they thought it was going to be something different, and they were very attracted to that. We run it on a just culture model, very people focused. As I say, I think we were, the top employer of ARS in the first couple of years in the region. People wanted to come, but also they had the protection of NHS terms and conditions that perhaps they didn't see they would get in general practices themselves. So we were able to offer, I guess it's the best of both worlds. It's the GP family run business feel with the NHS trust structure. So yeah, that was always the charm of it, really. And I think that's why many of the staff are very disappointed and sad about the demise of the trust, because I think people are concerned that we won't be able to replicate the same ethos going into other organisations. And that's the challenge for me, really, and the people that are tubing with me into the place partnership, that we need to make sure that we capture the best parts of what we've learned as a trust that works well, to make sure that those people stay with us, because our patient care is only as good as our folks, isn't it? So very much so.
I think I absolutely loved what you said around outliving the story, outliving the organization, because that's what it has become around how
Mm.
do you continue the fabulous work that's happening well beyond the confines of what was the organization. And that is really, really powerful. Lucy, any last words before we start? We're coming to the end of the hour, and it's been such a pleasure. But any last words, any words of wisdom you want to share before we start concluding today?
I'm not wise at all, and I think that's probably it, really. It's not. I don't think this has to be wise or rocket science, really. I think we all know and we all see every day the stuff that our patients are going through. We all see the bits of the system that are rubbish. Take one, go and speak to a colleague in another organization and start working on ways of making it better. It's not very hard, but I think for us, we've been consumed so much with this other work that we've almost felt like we've had to pause that type of work. So for me, I can't wait for the 1st of July so we can get back on with the job. So yeah, get on with hug a consultant, maybe.
What a nice, powerful way to conclude. I think it is really, really interesting how a good idea is a good idea, irrespective of the function and the form it takes. Because today, the conversation we've had, colleagues, over the last 2 years, we've spoken so often about successes. Today, we have truly spent time learning how a good idea continues to be a good idea and how do we make sure it outlives organizational form, because we get so caught up in who will run it, who will own it, who will feel powerful about it, that the true power comes by handing it away to someone else and being able to be in a place where you know the legacy of the cause you were believing in outlives the form that the legacy took initially to come into this being. And I think it was just absolutely phenomenal to hear the learning from you, Lucy, and then come towards the end where one starts seeing how the cause was so much wider, so much bigger, so much more important than just the form that the commissioners and the others started talking about. And I think while Dudley may not have done the first integrated care and held on to it, there will be many which will come, but none who would not look back at Dudley and learn from that, Lucy. And you have an amazing legacy to leave behind for the whole country. And you and your colleagues have done something which many could just speak of and not achieve. That story today, when my friend shared around the experience they had and the end of life care, that's what most of us would aspire for. And you should be so proud today of what you have achieved and led there.
Well, I'll certainly take that back to the team because I'm sure they'll be delighted to hear that feedback. It's brilliant because that's what we're all here for, isn't it?
Absolutely. So today, Lizzie, I mean, just to say, there are some things that one just doesn't want to end. And today's conversation was one of these sensory, cognitive, emotional, sense tingling things that you just don't want it to finish. But unfortunately, I have a rapidly approaching hour on the clock, and I know many colleagues wait till rather late in the evening so that they can get some time to talk about this. I think I have learned so much personally, and I think many colleagues who are on the call today would have learned about the integration and the amazing insight that you shared, both from your professional perspective, your professional role as the medical director, the leader of the system, but more importantly, from how you were personally vested because you are part of that community. And it means so much to you to leave that legacy behind for that improvement. I think, like we have always said, there is no one answer for every system. But for those who feel an integrated model with their acute trusts, with their acute providers, with their acute partners is the answer. Here's the learning of knowing what to do and what to steer clear of, because it takes more energy than is worth in terms of our ability to deliver. I mean, Lucy, you are both an amazing professional and an amazing person, and I can't thank you enough for the time you've spent and given us today and shared with us. I think for colleagues who are online, I cannot thank you all enough because these sessions would be completely meaningless without so many of you being there. I mean, there are 300 of you registered today. There are over 100 of you just on this particular platform. And I know we are live on multiple platforms across the social media. Given my age, I would probably not be able to name all of them, but I am absolutely convinced. I hope you all enjoyed it as much as I did today. Our next session will be in 4 weeks from now, and our guest then is Rob Webster, who is the chief exec of the North Yorkshire ICS, which has been heralded as one of the ones where the whole strategy of the ICS delivery is around primary care and the central role it plays. So it's a unique opportunity to take forward all the learning we have done today from the vertical integration into the larger space of the ICS to understand how at a whole regional space we can make a difference. Please use the QR code on your screens that you would see now to feedback, because your feedback is absolutely crucial for us to get these sessions right and make sure we are able to get it right for you. There are a couple of people I cannot do without, who I really have to thank. Sarah, who just makes this such a joy in the background, and the amazing Kelsey, who's joined us and taken it over from the Northeast London Foundation in. And you are such a dynamic duo to make this work so beautifully. Thank you so much. Colleagues, have a fabulous evening, and thank you again for your time today. Have a wonderful evening. Bye.